So regarding molecular and cytogenetic classifications of MDS, traditionally we have known the most about the cytogenetic aberrations that occur. So there are a set of cytogenetic abnormalities that, when found, can be helped to achieve the diagnosis of MDS. And these include, for example, loss of chromosome 5 or 7, in particular 5q, for example. In other cases, these chromosomal aberrations on their own do not enable the classification of MDS, but in the right context where there is sufficient dysplasia and evidence of cytopenia, they may be helpful in assigning clonality. At present, in the World Health Organization classification of MDS, there is only one cytogenetic aberration that is recognized as a distinctive entity, and that is MDS with deletion of chromosome 5q. At present, we've looked primarily for these aberrations by metaphase cytogenetics, by fluorescence in situ hybridization. But there are other technologies, such as array-based chromosome technologies or optical genomics, for example, that can look at these aberrations and find them in smaller size and with greater sensitivity. And this may also convey additional prognostic information. So this is an area of emerging diagnostics in MDS and cytogenetics, and finding the most appropriate ways to capture this additional information. I'll move now to the molecular side. And so regarding cytogenetics, the molecular technologies may also offer rapid ways of determining this information. So for example, by whole genome sequencing, it may be possible, and by RNA sequencing, to detect these chromosomal aberrations and gene fusions, and in one workflow perhaps to replace or complement some of the traditional cytogenetic techniques. Another means is by targeted sequencing, next generation sequencing. For example, an assay that we use has a set of DNA targets and a set of RNA targets as well. And those RNA targets encompass common gene fusions that are seen in MDS and myeloid malignancies. And back to the molecular aspects. So this is an area of very, very exciting investigation and an area that is being integrated as we speak, and likely to be affecting the next WHO classification in a major way. Right now, the only gene mutation that is listed in a provisional diagnostic category is that of SF3B1 mutations in MDS with ring sideroblasts. Traditionally, MDS with ring sideroblasts requires a threshold of 15% ring sideroblasts, which are red blood cells with iron trapped within the mitochondria. It's been recognized this is closely associated with mutations in a spliceosome factor called SF3B1, which, as it turns out, leads to missplicing of an iron exporter in mitochondria. So iron gets trapped in the mitochondria. In the latest edition of the World Health Organization classification of MDS, if one has at least 5% ring sideroblasts, but they're not meeting that 15% threshold, so if they at least have 5% and a mutation that's found in SF3B1, then that diagnosis of MDS can be achieved. There's a proposal afoot and lots of great evidence building that likely we should recognize SF3B1 mutated MDS as its own category with good prognosis and the potential to match patients to targeted therapy. In the current WHO classification, molecular features are incorporated in that if one finds mutations associated with MDS in the correct context, where someone has unexplained cytopenia and dysplasia, for example, it may help to achieve the diagnosis. I anticipate, based on our work and the work of others, that in the next iteration, as the evidence builds, we're likely to incorporate mutations more and more in the diagnosis of MDS and in WHO classifications. As an example, right now, if someone does not meet the morphological threshold of finding at least 10% dysplasia in at least one myeloid lineage, for example, if these patients do have, if you run an NGS panel or a whole genome panel and you find mutations associated with MDS in this type of patient, we can now consider this as a clonal cytopenia or of uncertain significance. CCUS is the acronym that's used. But as it turns out, in certain situations with certain mutations or combinations of mutations, it appears that these patients have a disease that is essentially, effectively, low-grade MDS and behaves like low-grade MDS. So we anticipate that in the forthcoming editions, there'll be more evidence and to present to incorporate these mutations in conjunction with the traditional morphological and cytopenia criteria, and to better achieve an early diagnosis and precise diagnosis of MDS that may then guide better prognostic anticipation and matching of treatment to patients and better management of patients and earlier management.